Hey everybody, welcome back to another episode of Hybrid Healing Hour. Today we are going to be discussing pain management, and we have a very special guest with us, Dr. Jonathan Kamerlink. Why don't you go ahead and tell our audience today a little bit about your background and how you got to where you are today?
Sure. Thanks, guys, for having me on the show today. So I'm an interventional pain specialist. I obviously went to medical school, just like every other medical doctor out there. I did a research fellowship for 2 years in orthopedic spine, as well as pain management for 2 years. Then I did my internship in internal medicine for 1 year, then 3 years of anesthesia residency, followed by 1 year of a interventional pain fellowship. I've been in practice now for 10 years. Beginning part of my career, I was doing general anesthesia as well as pain management. Now I just focus on interventional pain management.
Okay, wow. Extensive background.
Yes.
And have you noticed that the field of pain management has changed over the years?
Yeah, it has. I was actually reading an article this morning about, the opioid crisis. And, typically people think about pain management and they think that we just write a lot of prescriptions. And yeah, the beginning stages of the field of pain management, that was a lot of what we've done. But over the last 30 some years now, we've gone from prescribing medication more to doing interventions. And I think that interventions are going to increase. I think that because of the opioid crisis and the public's awareness about opioids and the detriments of being on opioid medications is increasing people's awareness that, maybe medicines are not always the solution, and maybe an injection might be the solution to their problem. And that could be a temporary solution. It could be a long-term strategy. But I look at it more of it's a continuum of care, and patients need to realize that when something happens, you don't immediately go have surgery. On the other hand, just taking pills all the time is not always a long-term solution as well too. So that's where kind of pain management kind of fits in the middle there, to provide patients with that quality of life with minimizing their potential negative outcomes, basically.
Perfect. You couldn't have said that any better. I love it. And so we're going to touch on all of those points today. And first I want to talk about, what is pain? Can you describe pain, and are there different types of pain?
Sure. So pain is a negative stimulus to the brain, basically. It's nature's way of telling us, hey, something's not right. Maybe something is broken. Maybe we're touching something that's sharp or something that's hot. It kind of keeps us in check. I mean, imagine you didn't feel any pain in your life. You touch all these hot things and you have burns all over your body, and conversely, you touch things that are super cold, and you can get burns as well too. Touching sharp objects as well, you'd have all these puncture marks all over your body, and that would make you susceptible to infection, and that really wouldn't bode too well.
Bleeding out.
I mean, all these little things.
Nothing good.
Right? Nothing good at all. So I think it's the warning alarms to our body from nature about what's going on, so that we don't do bad things to ourselves. That being said, there's a whole bunch of reasons why people could feel pain. My job as a pain specialist is to figure out, is it a psychological cause of their pain, or is there a true physical cause of people's pain? And just because it's psychological, that doesn't mean that people don't experience pain. They really do feel pain. But the generator of that pain is not what we think in the classic sense, like they burn themselves or they cut themselves or anything like that. Psychological illness can predispose people to those things. So we have to figure out what really is the root cause of people's pain.
Right. It's kind of like chicken or the egg. Which one comes first?
Correct. And then, then you go down that road of someone has chronic pain issues, and then it takes a toll on them psychologically. It makes them anxious. It makes them depressed. Makes them have a negative outlook on life. And that kind of spirals down because it makes their pain worse, because now they're not eating, they're not sleeping right, they're not their normal self, and the pain, it's a vicious cycle. So we got to kind of break it somehow.
Absolutely. I see that in our office, and I'm sure you see that every day in your clinic. A lot of people out there don't realize what people who suffer from chronic pain are going through. I mean, not only is it going to change your mood? I mean, I don't get headaches. And when I get a headache alone, I'm like, oh, don't talk to me. Like, I immediately change my personality, my mood. And then, but if I had chronic pain, I mean, these people are wondering, are they ever going to work again? And then when you don't sleep, you're definitely not well when you don't sleep. I mean, you're going to be irritable and crabby, and then that just spirals. So there's a lot more to it than just having pain that people don't realize. So can you tell us, when did clinicians start to become more aware of pain and start treating pain?
Sure. So, the field of pain management, it's a subspecialty of anesthesia. The formal fellowship probably started in the early to mid-90s. We're a much more juvenile field as compared to, like, let's say, internal medicine or orthopedics or general surgery. But it's been around for over 30 years now. And I think that, back in the 80s and 90s, we were recognizing that people were having these chronic pain issues. And at the time, our best treatment idea was throwing a bunch of opioid medications. That didn't really bode too well over the last, 35 years. I remember when I started anesthesia residency, which was 15 years ago now, and I saw that we were prescribing all these opioids to people for chronic pain. And I was like, wait a minute, this is not a great idea here. This is a highly addictive substance. And it all kind of stemmed from the fact that in the cancer world, they were using opioid medications. So they thought, well, why don't we try this with chronic pain patients? And nobody really kind of thought through that you're giving a physically as well as psychologically addicting medication to people, and what the long-term ramifications were. We've been ultra liberal with opioid medicines for a very long time, and since the opioid crisis and all these pill mills for the last, call it 10 years, we've been slowly whittling it down, and things have become much more stringent. I mean, look at the laws both at our state level of Florida and probably almost every state around the country now, and then the federal guidelines about opioids. It's much more stringent than it was before. So that kind of took that out as not a great idea to prescribe patients that. And so as a field, we had to think, well, maybe what else should we do for people? And, epidural steroid injections have been around for a really long time. It just wasn't, accepted widely, because people who would want to take an injection when you can just take a pill to take care of your pain. But then it begs the question about, like, well, do you really want to have to take a pill every single day? I mean, look at the rates of compliance with any medication, just blood pressure and diabetes medication. I think the average compliance rate is maybe 70% compliance rate.
Right.
So here you are, you're prescribing a bunch of opioids to people, and what if they take a lot more than you prescribed? And bad things can happen to people. And it's not even just pain. It's about looking at how functional people are, because pain for you or, pain for you, everyone is different. It's a personal experience. There's the physical experience as well as the psychological experience about it. And some people can barely handle a paper cut, and other people, like an arm can get chopped off, and
they're all right.
They're fine. Like,
exactly.
It's not a big deal. I mean,
it's subjective.
It's very much so. I mean, talk to anybody who had a gunshot wound. And
right.
They're like, oh, it wasn't a big deal. Like, you just had a hole put in part of your body, and it's not a big deal. And then other people, they get a little hangnail. Oh, my God, the world is ending. So you kind of have to put all those things together. And as time has gone on, I think the diagnostic imaging has really been the key for us to determining what the root cause is. Even though we treat pain, we don't just kind of treat it blindly. We look exactly what it is. We investigate what it is with x-rays or MRIs or CAT scans or ultrasounds to really see what is the root cause of the pain, because you can't just blindly treat it and then just hope for a good outcome. Maybe there are physicians out there that do that, but that's not really doing the right thing for a patient. What if it's a lot more serious? What if it's some type of mass or cancer that they're developing? What if it's, something, along those lines?
Exactly.
I
I look at it as like a Band-Aid. You're not curing the pain. You're just treating the pain. And
true. I mean, you kind of are treating it, because, I'll give you the classic example of a lumbar disc herniation, and come in and say, "Oh, my back, my leg, they're killing me. I can't take it. I can't sit. I can't lay down. I can't sleep. I can't work." And you can do an injection for them. They feel great, and they're great in perpetuity from that point on. And you prevent a lot of people from needing surgery. Unfortunately, there are some people it's beyond what an injection can help, and they do need to go on to have some type of surgery, whether it's back or some type of other orthopedic type of surgery. But there's a lot of people we can help without needing surgical intervention.
Right. What I was saying is like the pills are just treating the pain.
True.
Right?
Correct. They're
Whereas
just masking it.
Right. They're just masking
it.
it.
That's
Exactly.
it.
And like you said, there could be a deeper cause.
And then another consequence of the opioid crisis is that now there's a stigma with chronic pain patients where clinicians or healthcare workers feel that maybe they're pain seeking, they're pain medication seeking. And it's a shame because a lot of these people are suffering with chronic pain. Is back pain the most commonly seen pain in your practice? Is that
by far. I think low back pain is the leading cause of any doctor visit around the country. I think it's the last statistic I want to say it's like a third of medical visits are related to some type of back issue.
Yeah.
And I agree with you. The stigma of opioid medicines is real. I mean, the pharmacies now don't carry a lot of these opioids. Every pill is basically accounted for now. And with the prescription monitoring program, we can see exactly when every last prescription was filled. And the pharmacists in Florida, they are liable for this now. Whereas before, it was just the physician that was liable. The pharmacy, the pharmacist, they're all part of that care continuum. And if they think it's not appropriate for that medication, they can refuse to fill that prescription. I don't always agree with it.
Right.
And conversely, there are lots of cancer pain that we manage in our practice, and these are literally people dying of cancer, and they can't get their pain medication, or they don't have the full gamut of different opioid medicines that are commercially available. And so I agree with you. The pendulum has swung from one extreme to the other, and there just has to be a very conscientious approach to this. Not everybody needs an opioid, but some people really do need an opioid. And unfortunately, some of these cancer patients, they need the super strength opioids because they're at an end of the road and their cancer is just eroding their entire body.
Yeah.
Yeah. And that's unfortunate. And plus a lot of things have been on back order as well since COVID, and that goes in line with many other medications.
Yeah, out of all the different medical supplies we use, that's the only one that continues to be on back order.
Mm-hmm. So how much of that is truly on back order?
I don't think it's really back ordered.
Gotcha.
I think that the manufacturers and the pharmacies, I think they have certain quotas that they have to comply with now. They can only dispense so much of it in a month's time. And then there's the liability of it, that the pharmacies don't want to stock it because someone could break into their pharmacy.
Absolutely.
I mean, look at all the amount of petty crime we're seeing across the country right now.
Yeah. I know.
And who's to say that someone's not going to walk into a pharmacy, hey, give me all the morphine or Dilaudid you have. So they just don't want that.
Absolutely.
And it's a really tough situation. Unfortunately, I'm the one stuck in the middle because now the patient looks at me and says, hey, you're my advocate. I can't get these meds without you. And then we have to call pharmacy to pharmacy. We have to beg and plead. We have to wait for medications to be delivered to the pharmacy. And it's really challenging.
Absolutely. And so on that note, do you help people who don't want to be on opiates anymore? Yeah. Do you help them get off of them?
So I take quite a few patients off of opioids every year. They'll come to me and they'll be on some high doses of opioids. And I have a very honest conversation with them. And I ask them, well, how's your pain on this regimen? Well, it's not so great. Well, why are you taking this medication? Well, it's the only thing that works for me. Well, you're taking a very dangerous medication. It has a whole bunch of legal ramifications from it, a whole bunch of compliance issues with it, and it's marginally helping your pain. So why take something when it has all these negative things to it?
And a lot of side effects. People
Tons
don't
of
realize the side effects from opiates. I mean, you've got fatigue,
Respiratory depression.
Exactly. Constipation is huge.
Oh, huge. Constipation is enormous.
And actually, they can cause sleep disruptions and depression and anxiety themselves.
Of course, absolutely. So when you have that conversation, and look, there are numerous patients that have been on opioids for years. The probability of getting off of them is near 0%. But every once in a while, you'll have a patient that, when you have that talk with them, it resonates with them. And they'll say, well, that kind of makes sense. Maybe there's something to it. Maybe there's a better way to do that. And they see all the steps that they have to go through to get their prescriptions. And they come to a point, well, this isn't really worth it. And I don't really want to be on this stuff anymore. So there's a lot of people that want to do that, and I take care of them. And it's not as difficult as people think it is. Withdrawing from, like, let's say, alcohol or benzodiazepines, that's way more dangerous than opioids. When you suddenly stop opioid medication, it's uncomfortable, feels like the flu, feels like your bones are breaking, but nobody dies from that. They maybe get a little bit of tachycardia, maybe a little hypertension. Some people can argue
Sweats.
some people argue that can predispose people to heart attacks and stroke, because of those changes in their hemodynamics. But in terms of, the psychological aspects of opioids, it doesn't kill anybody. Benzos, that's really serious.
You can actually have seizures from benzo or alcohol withdrawal, whereas not with opiates. Yep. I always tell people the same thing. You're going to feel like you're dying, but you won't.
Right.
Whereas the other ones are much more risky.
Yeah, and even the combination of medications has been flagged at the pharmacy. So if it's an opioid medication in conjunction with a muscle relaxer or a benzodiazepine, that's a huge red flag. And the pharmacies are very reluctant to dispense all those medications. The insurance companies don't want to cover it, including Medicare. So it shows you that the recognition of these combination of medications is at multiple levels. And again, it all depends on how long the patient has been on that. Patients psychologically, well, my doctor told me I have to take this. Well, that's poor medical advice that was given 15, 20 years ago. I mean, I wasn't practicing then. I would have told you the same thing back then. But, they have this ingrained in their head. Oh, my doctor told me I had to take that. Well, it was not great medical advice that you were getting. And, the patients are also complicit as well, too. They sought out those doctors that were going to prescribe all these medicines to them. I mean, look at the pill mills. Mm-hmm. Were those doctors negligent for them? Yeah, they were negligent. But those patients were negligent too.
Exactly. They knew where they were going.
They were complicit in it. Nobody forced them to, write a check or, pay cash for those visits, but they did it because they wanted those medications and they wanted it as quickly and easily as possible, whether it was for real medical purposes or to get high. I don't know. But now we're paying the price. I mean, look at the rates of illegal substance abuse now. I mean, look at the rates of opioid overdoses now. I mean,
it's tragic.
It's tragic. And now, because of the changes of opioid regulations, we're probably going to see an increased amount of street drugs. We're going to see an increase in HIV and hepatitis.
We already have, yeah.
And, that's just going to go hand in hand, and it'll probably take a few years to peak out. It'll plateau probably in the next few years, and then it'll slowly trickle down. That brings us to mental health crisis that we're seeing, because it's like all these things. Why are these people taking? Is it really because of their pain? Are they self-treating and just lying to physicians about their pain because they just want to take the opioid or whatever medicine to kind of dull the senses? It's a really tough thing, and unfortunately, America doesn't want to recognize that we're in a mental health crisis too.
Of course. Now, do you do Suboxone or methadone or bupropion?
Right. So I don't prescribe Suboxone because that's currently only FDA approved for history of substance abuse.
Substance abuse, yeah.
But the root drug, buprenorphine, we do prescribe it, whether it could be a Butrans patch, which is FDA approved for managing chronic pain, as well as Belbuca, which is a sublingual film that also has buprenorphine, both of which are FDA approved. Now, the reality of it, it's buprenorphine. Buprenorphine is buprenorphine, but we're still kind of guided by FDA regulation. The the DEA. The DEA did get rid of the waiver X for Suboxone, including the state of Florida. So any physician now that has a DEA license can prescribe Suboxone. Is there a difference between the 8 milligrams of buprenorphine and Suboxone versus the, depending if you're using the patch, could be as high as 20 micrograms per hour, or the Belbuca film, which I think goes up to, don't quote me, but I want to say it goes up to 700 micrograms. Probably not. I mean, there's a ceiling effect.
I was just about to ask that.
So the more and more you take of it, it doesn't cause respiratory depression. Suboxone does have naloxone in it. I believe it's in the core of the pill, so you can't crush it and snort it. But people crush and snort anything. It could be gabapentin. It can be Wellbutrin. It can be Lyrica. It could be Xanax. I mean, you name it. If it's a pill,
there's abuse of anything.
There's abuse in anything. I mean, it's crazy what people do to themselves. But I think that there's a role for buprenorphine products. I think that's where I think the market is going to go there. I think the federal.
Can you explain, like, that being a partial opioid agonist? So can you explain to our audience a little bit about that?
So look at opioids as on a continuum. On one end, you have an opioid, a pure opioid medicine like a fentanyl, which you hear is a street drug, which there is real medical uses for fentanyl. We use it in the operating room all the time. There's morphine, there's oxycodone, there's hydrocodone, there's Percocet, there's Vicodin, even tramadol itself works at the opioid receptor. And then the other end of the spectrum, think of a opioid antagonist, basically the reversal for an opioid medicine. You can think of Narcan, which is naloxone, or naltrexone. Those completely reverse the effects of an opioid medicine. Buprenorphine is right in the middle. It kind of works like a full-acting opioid, but it kind of acts like a reversing type of drug. But they have, like you mentioned, the ceiling effect. So you could take, a million milligrams of it. At a certain point, it doesn't do anything more. It doesn't cause respiratory depression. I really haven't seen anything about the polypharmacy of it. Like, let's say if you mixed a buprenorphine containing product with like a Xanax or a muscle relaxer, what's the synergistic activity? And the reality of it, there probably is.
There is. I used to work in drug addiction.
There is a synergistic effect. And the combination of medications, which we do use in certain circumstances, let's say it's a post-surgical type of situation. Someone just had a joint replacement, or they had spine surgery, or a major abdominal procedure. Yeah, they need a lot of different medications to control their pain, but that's in a controlled setting. That's under the care of a hospital or a surgery center. And so our ability to make sure that we're not overdosing a patient is much better. There still can be errors with that. I have seen those, unfortunately. But using combination of medications for managing chronic pain is not always such a great idea. And whether we like it or not, our bodies develop tolerance to all these medicines. I mean, you guys see it with even cardiovascular drugs. I mean, you could have somebody on a beta blocker for years, and then all of a sudden, it's not really working too well. And it's probably because their body's adapted to it.
Right.
And the receptors have changed a little bit. And then you got to switch them to a calcium channel blocker or ACE inhibitor, or, all these different drugs. So it doesn't matter that it's necessarily an opioid medicine. You can even a Lyrica type medicine. People probably develop tolerance.
Ozempic is a big one we're seeing now.
Really?
People are developing, they think that I can keep taking it, I'll keep losing weight, and they find that they plateau, and some people stop losing weight on it.
Wow.
It hits everybody.
It just shows you can only play with nature so much.
Absolutely. And so can you talk about, like, we're talking about chronic pain. I mean, but there's acute pain, there's chronic pain, there's intermittent pain. Can you kind of touch on
Sure.
that?
So the definition of chronic pain, depending on what source you're going to, it could be as little as 8 weeks of persistent pain, and it could be as much as like 6 months. Everybody has a kind of a different definition to it. I would say chronic to me is like more than 6 to 8 weeks of pain. I think that's kind of a fair statement there. Anything less than that is acute pain. I would say that's like it happened a few days ago, a few weeks ago, and intermittent or intermediate, I should say, is somewhere in between there. How we approach those things, I don't think is really that different, aside from like post-surgical or someone has a major trauma and they break a bone. But how we prescribe medicines, that really does affect it because, even in the world of anesthesia, you want to use some preemptive analgesia, preemptive, pain relievers, whether it's some type of nerve block you're doing, before surgery or immediately after or during the procedure itself, and that will help to control the pain symptoms for the patient so that they are not dependent on so much pain medicine afterwards. In my practice, we're doing a lot of injections because people have exhausted medication at that point. They've tried the simple things already. They've tried the Tylenols and the anti-inflammatories. Maybe they tried an oral steroid pack, and their pain symptoms are still persistent and they're pretty debilitated. You ask them, are you able to work? No, I'm not able to go to work. Are you able to make a living? No, I can't make a living right now. So it's about that speed to return people to as functional of a status as you possibly can.
I like how you word that, to functional, right? It's not, a lot of times people want to get back to where they were before the injury or whatever is causing their pain. And sometimes it comes down to a matter of accepting that they have pain, that they will have chronic pain, and they might not be able to get exactly back to where they were before, but to get them functional.
Right. So let's talk about two different scenarios there. Let's talk about a younger patient, someone under the age of 65 that has a disc herniation. They'll come in and complain about low back pain, radiating down to the leg, severe lancetating pain. And you can do an epidural for them. They feel better, and then they follow up and say, well, I still have some numbness in my leg, or I have numbness in my hand because of that. And that numbness itself can be painful, not as bad as that severe lancetating pain, but that numbness can take months to subside. The nervous system does not respond immediately. You can get rid of that severe pain, but some of that lagging, aching pain, that may take months to get better. Mm-hmm. We don't really have any way to speed up that process quite yet. I'm sure eventually medicine will have ways to help to move that process along, but we're just not there yet. Conversely, you have an elderly patient above the age of 65 that has a degenerative process, arthritic type of process in their spine, and their pain is going to vacillate over time. Some days it'll be 1 or 2 out of 10. They're very functional. They're able to get around, move, and do all their normal stuff. And sometimes the pain is 10 out of 10, and they can't do all their normal stuff. And you have to be honest with patients that the probability of getting them 100% pain relief is pretty low. And you don't want to discourage patients. But on the other hand, I don't lie to patients. I'm very honest with people. And we don't know what it'll be. I do injections all the time, and some people I do get 100% better. But sometimes I only get them like 60 or 70% better. And they have to be accepting of what that is. To be chasing that little nominal amount of pain that they have, sometimes they do things that hurt themselves. They'll go and have that aggressive type of surgery, and then they don't get the outcome that they hoped, or they had a complication from that surgery, and then they have regret about doing that. So do you want a patient to be part of that decision-making? Yes. But part of that decision-making is about being honest with your patient. There are lots of physicians, unfortunately, that give these false expectations that, oh, we're going to do this injection, we're going to do this procedure, whatever it is, not just to feel the pain, but you are going to be 100% better. I don't know anything in life,
that is 100%.
That 100%. Even when I watch TV and we 100% guarantee, I'm like, no, there's no way. There's no way that is happening. So that's why I focus on the functionality of patients. And I think that our field has to develop better clinical tools to really assess that functionality. We have all these different fancy surveys that are used more for research purposes. They're cumbersome for patients to kind of fill out. You have to score them. There's not amazing clinical tools. There's no electronic health record that has it built in that you can have a patient fill it out and score it and integrate with the electronic health record, so that we can see that. And I'm just using a generic term for a survey, but imagine you could trend that survey over time, over whatever treatment that you're doing. I mean, even for you guys, for blood pressure, I mean, you guys are able to track how their blood pressure is doing,
right,
and how much variance is doing. We don't have that. I mean, the best tool we have is what's your pain today? 0 out of 10. I mean, I have some people go, oh, my pain is 10 out of 10. So you feel like you're dying every day? Yes, I feel like I'm dying. You don't look like you're dying.
Right.
I get you're in pain, but let's be real about what 10 out of 10 pain is. Mm-hmm. And this was largely propagated by the federal government. They wanted the surveys that all inpatients complete was so focused on managing pain that every hospital for the last 20 some years has been so focused on that. And I get that, and it is an important part. And there have been a lot of complaints about patients' need not being met in a hospital, whether they asked for pain medicine, it wasn't given to them, they didn't have a comprehensive pain management plan written out for them. Mm-hmm. And so I understand that. But on the other hand, then there was this huge push of, let's just push more and more opioids. And then they were overdosing people.
Right.
I mean, there's been countless stories, countless malpractice lawsuits of people being over-sedated in the hospital because they claimed that their pain was uncontrolled and they just got prescribed and dispensed all this pain medicine. So it's about being realistic about what can and can't be done.
Absolutely. Now, talking about injections, so can you describe, when you say an injection, is that an epidural? And is that cortisone? Can you kind of tell us some other alternative treatment options other than pills?
So injections is a very generic term. An epidural steroid injection is a type of injection that we do. An epidural is actually a space in the spinal column where we're putting a steroid. I like to say that the field of pain management is like real estate. It's all about location. It's about being as targeted of a treatment as you possibly can. It's about getting as close to what you think that the problem is and delivering some type of medication to help ameliorate that pain symptom. Most of the time it's a steroid that we're injecting. But on the horizon, I think that we will have different biologic agents that we can inject, whether it's in the spine or joints, that will help rejuvenate that tissue. Right now, a lot of the orthopedic surgeons, they use these viscosupplement injections, and they're putting it primarily in the knees. I think there's off-label use for in the hips and in the shoulders as well too. I think it makes sense. Yeah. But again, only FDA.
It's giving a cushion, essentially.
Correct. The FDA only approves it for knee injections. But I think probably in the next 10 to 15 years, we will have these different supplements that we'll be able to inject that will help regenerate the tissue. It won't make you can't take an 80-year-old and make them 20, but if you can take an 80-year-old and make them 65, maybe that's enough to help significantly reduce their pain, provide them with good functionality of their life, and either buy them some time or maybe prevent them from needing surgery. There's still going to be a need for surgery. I mean, that's not going away. Joint replacements is
but unfortunately, not everybody's a surgical candidate.
Correct. Not everybody is a surgical candidate. But the question is maybe some of these things that we can inject, if it can help retard the degradation of the joint, so that whatever lifespan that they have left, it doesn't degenerate to the point that they need a knee or a hip replacement or a shoulder replacement, maybe that's a solution to part of it.
So I know they do like PRP in joints.
Sure.
Is there anybody doing that in the spine or anywhere else?
Yeah, so PRP is gaining a lot of popularity. There's definitely data to support it, and with certain stringent type of protocols, maybe that's where we go in the future. Maybe injecting steroids into joints in the spine, maybe that wasn't the best thing, but that's all we really had up until now. PRP, there's issues with it. You still have to harvest it with patients. You have to spin it down. There's always a chance of contamination when you're doing that. It is, we saw that also with steroids. There was a whole case, was it 10, 15 years ago, where steroids were contaminated with fungus, and I think it was like 50 to 150 people died in the whole country because of that. That's a possibility as well too, but I think the next horizon will be these biologic agents that can help to restore the joints.
Do you do rhizotomies as well?
Yes.
And do you want to explain that?
Sure. So a rhizotomy, also known as a radiofrequency ablation, RFA is what we call it for short. It's basically burning little sensory nerves that go to the facet joints. That's the most posterior aspect of the how should I describe it? Posterior would be the farthest back part of the spine, basically, that develops arthritis over time. So we can't really, from an interventional standpoint, you could put steroid in there, help to calm it down, but a lot of times it doesn't last a long time. So doing an ablation where we burn the little sensory nerves that go to those facet joints so you don't feel the pain, maybe that's an option for a lot of people. Again, chronic low back pain being the most common reason people go to see a doctor, it helps to, again, control symptoms, prevents people from needing back surgery, because back surgery is not 100% successful, and helps to provide people with good quality of their life for whatever they have left.
Sure. And so what is approximately like a good outcome? How long does a rhizotomy last?
So in terms of outcome, we want to see at least from the ablation itself, we want to see at least the 50 to 60% reduction in pain. And we want it to last for at least 6 months.
Okay. And how long does an epidural last? And do you have to get a series of them, or what do you recommend?
We don't do a series. That's a very old way of kind of practicing.
Okay.
Probably because that was before we used fluoroscopy. That's the X-ray guidance to epidurals, and I think statistically, if you did an epidural blindly without guidance, 1 in 3 of them was actually in the epidural space. So I think that's where they came up with that series as theory.
So now you can see much better.
Now we can see a whole lot better. Yes, that is absolutely true. So now the practice is you do an epidural and you see how somebody does. If you're able to significantly reduce their pain by 50, 60, 70, 80%, maybe you hold off on a second one, kind of see how things go. Maybe nature can kind of get rid of the rest of it, maybe some physical therapy. But you got to be careful about that steroid exposure. You do too much of it, you can develop adrenal insufficiency, osteoporosis, you can develop avascular necrosis of joints. I've seen all these complications. They're real.
And that's what, people don't realize that steroids are not benign.
Right.
And we even have to be careful in the joints. I know with joint injections, which I do in our office, I have to wait at least 3 months between joint injections. Is there something like that you guys have a protocol?
So I will do up to 4 epidural steroid injections in a year's time.
In a year, okay.
And I wait at least 2 weeks in between of them. But it's not good to do them every 2 weeks. That's maybe just once in a while that you can do that. So you do need to be careful about that. And that's why ablations, like you were mentioning before, which is just for pure axial back pain, that's no sciatic pain or what we call radicular type of pain, that's a good alternative, because now you can do a procedure for someone, not expose them to steroids, and still get them to have decent pain relief.
And then, have you ever heard of prolozone therapy?
Yeah.
Are you familiar with that?
Yeah. So prolotherapy is the practice of putting needles into some type of tissue. Usually it's muscle or tendon, with some type of saline, And the whole point of that is to cause a inflammatory reaction in the whatever where you're putting the actual needle, so that it causes a healing process, basically. Not too different than what we use is called a trigger point injection. The problem is anytime you pierce a muscle or a tendon, that creates a little defect in that. You do that too often, it's like tenderizing meat. It reduces the integrity of those fibers, so that it could be very detrimental to people. Once in a while, not a big deal. But the ozone therapy is they take this hyperoxygenated gas and they inject it in there. I don't see any merit to it. I don't think it makes any sense. Probably propagated because of financial reasons, but there's no real medicine to substantiate it.
Okay. And some alternative treatments that, we practice in our office is like going back to like the connection with chronic pain and mental health is, practicing some mindfulness. And when you do things like that, you can scan your body mentally and kind of figure out, is this a physical pain or a somatic type of pain, and see if you can eliminate that. And then we've had people who have chronic back pain and they do Pilates, and which really strengthens their core, and they've been able to get rid of that extra little bit of pain, that they were having. So we're big fans of like physical therapy, core strengthening exercises. And I'm a big fan of like with joint pains, building the muscle above and below the joint. And a lot of people just don't realize the power of exercise and working out. Even with limited range of motion, there is always something you can do. I mean, they have chair yoga. They have, things like that to help keep you mobile. So I always like to talk about that. But what are your thoughts on like medical marijuana?
So there's really not a lot of data to support it. And my concern about the smoking of marijuana products is twofold. Number one, smoking anything, whether it's marijuana, tobacco, you name it, is detrimental to our health. Smoke is a carcinogenic substance. So am I concerned that we will see this propagation of, everyone accepts smoking marijuana now, and then we're going to see an uptick in the amount of lung cancer that we're going to see out there? And I think that's a real concern. At least with cigarettes, there's some filter. I'll use that loosely. With the smoking of marijuana products, there is no filter. But on the other hand, people are probably not smoking marijuana as frequently as they are tobacco products, so maybe that kind of washes that out. The edibles, I think, is a much safer option. There have been a lot of issues with consistency, amount of THC and CBD in those products, so from one batch to the next. But in terms of negative outcomes, I think that's probably fine. Some patients, they like it. They think it does help their pain, and they rather take that than an opioid. Other patients have tried it and said it did nothing for them, just made them feel kind of out of it and really hungry. And so I think it's not a one-size-fits-all. I think it's reasonable to maybe consider the edibles, the smoking. I'm very much against that.
They have tinctures. They have so many different forms now other than smokable. Yeah.
Right. The smokable, I think, should be banned. I think that's not because of the mind-altering properties. I'm more concerned about the medical ramifications from that. But in terms of my own practice, I don't prescribe any of the CBD products. I mean, right now you still need to have it, but it's on the ballot later this year for using it for recreational purposes, and I imagine it'll probably get passed in the state of Florida, and then there won't be any prescription or license that will be needed for it. But patients,
once again, it's subjective, right?
Right.
Everyone has their own tolerance level. I mean, same with pain meds. I mean, some people are like, I don't like how I feel. It makes me dizzy and tired, and I didn't have that much pain relief. So yeah, it goes hand in hand with all the other remedies.
I mean, if you compare serious ramifications of marijuana products, just the mind-altering properties, it doesn't cause respiratory depression like we see with opioids. So, I mean, it's probably safer. On the other hand, people are going to smoke marijuana or take edibles, and they're going to go drive their car, and they're getting car accidents. And that's, driving under the influence. I think, for a long time, we only consider that to be alcohol. But now between marijuana products, these microdosing of psychedelic medications out there, people are taking ketamine at home. It's no longer just alcohol. It's all these mind-altering substances.
Regardless of what your remedy is, you got to do it responsibly.
Yeah. And unfortunately, a lot of patients do not have that sense of responsibility. They don't have that little maybe I shouldn't go use my car when I take this stuff.
And I mean, the same goes, you're not supposed to drive with opiates in your system either, and benzos. People pop a Xanax to drive,
lots of people do.
Well, you kind of need that for South Florida. The fires are terrible, but that's a different story.
So I have one last question.
Sure.
At what point do you decide when it's time for that patient to turn to surgery?
So that's a twofold thing. First, it depends on what they've tried up until that point. Have they exhausted all the medications and the physical therapy and the injections? And number two, how is it affecting their quality of life? If it's like, I can't play golf, I don't know if that's necessarily a decision maker. But if it's, I can't even get up and go to the kitchen and make myself lunch, or I can't take the trash out, or I'm having a hard time just walking to the bathroom, that's a different situation. And I find that psychologically, when the patient has realized themselves that they've tried everything and it is negatively affecting them, they can go in to have surgery with peace of mind. Because if there is a negative outcome, at least they can say, look, I tried everything. My quality of life was terrible. I couldn't exist like this anymore. And so something bad happened to me. It's okay. On the other hand, when someone hasn't exhausted all those non-surgical options, it's not good either. It makes the surgeon not look so good. But any reasonable spine surgeon or orthopedic surgeon will tell you, try everything non-surgical first.
Right.
Yeah.
Surgery is the court of last resort, and the patients know themselves when it's time to go do that. They realize that I just can't do this anymore. I don't want to take these pills. I don't want to keep needing these injections, waking up every morning, severe debilitated pain. Then they know. There are certain times that we kind of push them in that direction because of what we as our knowledge as physicians of impending doom for them. But one of the issues that I see now, especially with the aging population, is that when you do see degeneration, you see a significant decline, but the patient is young enough and healthy enough to have surgery. Sometimes I recommend them to kind of look at that a little sooner than later, because let's say they're 65 and they have this problem, and they might have maybe a little high blood pressure, high cholesterol, but they haven't had a heart attack, no stroke, nothing really major. And then what if they wait and now they're 85 and 90 years old, and let's say that hip is extremely arthritic and now they're too old and frail to have that surgery. Maybe they should have done that when they were younger, and then this would afford them better quality of life. I mean, we don't have any randomized prospective studies to kind of look at these things.
Right.
Yeah.
It's completely individualized, though, too, because, you can have an 80-year-old who's still playing tennis and golfing, and then you have one that's, a wheelchair bound.
This is stuff that we have to look in population health. The best thing was like the Framingham study, where they studied, these people in Framingham, Massachusetts for decades. That's the way to only elucidate that. You can't have a prospective randomized trial where you are withholding, certain types of treatments for people just to see how they do. I mean, that would be, what's the word I'm looking for? I'm blanking on it. There's a certain term for it. It's like withholding chemotherapy for a cancer patient. I mean,
right.
It's the same type of deal.
Not ethical.
Unethical.
Unethical.
Yeah, it would be unethical
Right.
to do that. But you try to do the best you can for patients.
Absolutely. I think this is very informative.
Yep.
Thank you so much for spending your afternoon coming to do this with us. you tell our audience how they can find you?
Sure. So my practice is Florida Spine Associates. We have locations from Fort Lauderdale all the way up to West Palm Beach. I personally see patients in our Boca Raton office. Our website is www.floridaspineassociates.com. Our phone number is 561-495-9511. And we are the full continuum of spinal care. So we have 5 pain specialists and we have 3 orthopedic spine surgeons in our group. And we try to do the best thing we can for patients.
Thank you so much. And I'll also attach that to the show notes.
Yeah. Thank you.
Thank you, guys.
The information contained in this podcast is provided for informational and educational purposes only and is not intended for the purposes of diagnosing, curing, treating, or preventing any disease. This podcast is provided on the understanding that it does not constitute medical or other professional advice or services. Before using any products or services referenced on this podcast, consult with your healthcare provider, carefully read all labels, and heed all directions and cautions that accompany the products. Information found or received through the podcast should not be used in place of a consultation or advice from a healthcare provider. If you suspect you have a medical problem or should you have any healthcare questions, please promptly call or see your healthcare provider. This podcast, including Dr. Brian Marias, Deanna Weilbacher, and Hybrid Medical Solution, do not claim responsibility for any adverse effects from the use of information contained herein. Opinions of guests are their own, and this podcast does not endorse or accept responsibility for any statements made by the guests. This podcast does not make any representations or warranties about guest qualifications or credibility. This podcast may contain paid endorsements and advertisements for products or services. Individuals on this podcast may have a direct or indirect financial interest in products or services referenced.
If you would like to submit any questions or if you have any topics you would be interested in hearing about on future episodes, please contact us through our website, www.hybridmedicalsolution.com. That is solution with no S at the end. Follow us on Instagram and Facebook, all under Hybrid Medical Solution.